Well, hi again, everyone. I'm Greg Flynn, and welcome into Health Talk Mississippi. This is a podcast designed to entertain and inform and hopefully educate you a little bit about the things going on in the health world here in the great state of Mississippi. Today, we're going to talk about report cards. Now, everybody probably remembers, you got your report card, you brought it home to mom and dad, and if it was really good, you wanted to get it right in front of them, so hopefully you could see a treat. If not, you kind of slipped it in there with the rest of the mail for the day, and you hoped that they saw it and just signed it really quick and gave it back to you. Well, Mississippi has its health report card for 2025, and here to talk about that with us is Dr. Dan Edney. He's the Executive Director of the Mississippi State Department of Health and our State Health Officer. And Doc, just like any other kind of report card, there's good and there's bad to it, isn't it?
And a lot of room for improvement.
We like that. The needs improvement versus having really bad score on there. We know that there are certainly, you go into it, you've told everybody, when we're that far at the bottom of things, it's hard to make big strides right away. But you're seeing that we are seeing some movement off the bottom of the national rankings in things like obesity, hypertension, diabetes.
Right. Really across the board, we have great opportunity, but we are seeing, the needle has begun to move, and over a 3-year period, the trend is a favorable trend and has finally moved us off the bottom. Not very far, but much better than we were 3, 4, 5 years ago.
As you've mentioned, when you're 50th, or actually you can go further than 50 on these rankings because of the territories and other factors that are played into it. You can actually be below 50, right?
Yeah, in 2021, 2022, we were truly below 50. In the state rankings, we would keep being shown as 50th, but there was such a drop-off between 48, 49, and then us. There was a large gap. That was really my biggest concern, was just how far back from the pack we were. But I was really excited that in 23 we saw us close that gap, and we had more state rankings in health that had improved than any other state in the country had that year. We had 19 different health metrics that we had improved upon, and that closed that gap. We were still 50th in 2023, but what I'm so proud of with this report card is the fact that in 2024 we moved to 49th, which was wonderful. Hard to make a big deal out of 1 year, but in 2025, just a month ago, we received our rankings and had moved to 48th. So to have begun so far back, it's like a long distance runner who's all the way at the back of the pack. We had to close that gap, and now we're moving up among our peer states, and it really doesn't matter to me what number we are. What matters to me is that we're reducing preventable death, that we're extending life expectancy, that we're reducing maternal infant death in this state, that we're reducing the overall mortality rate. That's what's important. But as you do that, you move up in the rankings, and that's what we're doing.
I think the most fascinating concept you've had everyone to focus on over the last 2-3 years now is taking a look at what you call those potential years of life lost before age 75 due to preventable deaths. And this year, you see, it's a big number. It says 189,566. So can you explain,
Sure.
Why that's such an important number?
Yes, because that number is pointing out the burden of preventable death that we have in the state. We still lead the country in preventable deaths. That really worries me. That means we have more Mississippians dying unnecessarily than the rest of the country has. And that's just a metric that we have to keep improving. But this is the third year in a row that we have trended down that number. And what potential years of life lost before age 75 means is every year we take each death that occurs in the state, a Mississippian who died before age 75, before their 75th birthday, and we subtract the difference between the years and the months even of when they died less than 75, and that number goes into the pot. And so for every one of our 35,000 last year, 245 deaths, we looked at each one, and if they were younger than 75, then we looked at the difference between their age of death and age 75 and put it into that category and added up each one of those. So a good example is we have a baby who dies at 1. Well, that's 74 years of potential life lost, and that 74 years goes into the bucket. And then we add all those up, and that's how we came up with 189,566. But, Greg, 3 years ago, that number was more than 250,000. And last year was about 195,000 plus, and then this year, below 190,000. So we're trending in the right direction, and it's always, y'all know, I always ask, what's the number? That's the number I'm looking for when we close the books at the end of the year. What are the potential years of life lost before age 75? Because it tells me so much in terms of progress for preventable death in our state.
Well, and you use that kind of a barometer there of age 75 because that's about what our life expectancy is here in the state, which is a little
generous. it actually a little bit less than that, but it's a good number to peg as a reasonable life expectancy for the state, which is far too low. The life expectancy in Hawaii is 80. Ours is less than 75, and that's because we lose too many young Mississippians to preventable deaths. So we, leading the nation in infant mortality, each one of those babies that dies, that reduces our life expectancy. And, young people dying in car wrecks, young people dying of overdoses. There's a lot of our excess mortality is among the young, our infants, our children, our adolescents, those less than 35 for many reasons, and that really shifts our life expectancy much lower than other states. So that's why we are really focusing on maternal infant mortality, because those are all young people and babies dying. And then we've been focusing on opioid deaths, which we've made great success in opioid deaths, and looking at firearm-related injuries, which tend to be mostly all young people. Leading cause of death for our teenagers age 15 to 18 is homicides, and they're virtually all by handguns. So that really drives our accidental death rate, which are mostly young people, which causes us to have an abnormally low life expectancy.
Well, and the focus over the last year, and it's going to be continue as we go into 2026, as you said, was really focusing on the infant and maternal, because you want a healthy mom to give birth to a healthy baby that's going to have a great chance at life.
That's right.
And not only are you going to talk about, well, they're not only going to live longer, which is great, and to have families blossom, but it's also going to help this state economically, because as you say, public health is public wealth, and the healthier all these folks are and the longer they live, the more productive they can be, and just help us set the state on fire.
And we've calculated the cost of our leading causes of death in the state, and for maternal infant death, the cost to the negative impact to our economy, the cost of that for all of us is about $3.2 billion a year. Because of all the lost opportunity, the cost of taking care of unhealthy newborns in the NICUs that don't survive, the cost of poor maternal health, taking care of our pregnant moms just is exceedingly high in our state. We're doing better that our moms are not, we don't have as many moms dying because of their pregnancy as we did. Our mortality rate is still too high for our moms, but we have fewer women dying because of their pregnancy, but they're still really sick, and that excess morbidity, they don't die, but some of them come mighty close to dying, and they don't show up in the mortality statistics, but they're never the same. They may have a weak heart or weak kidneys or diabetes, hypertension for the rest of their lives. They may have had a stroke, related to the pregnancy, and they're never the same. So we're doing better helping them survive, but we've got to do a better job helping them thrive, because you cannot disconnect maternal health from infant mortality. The big driver of our high level of infant mortality relates to preterm, low gestational weight babies, and all those connect straight over to the health of the mom. And we have too many of our pregnancies are unhealthy in the state.
Well, that's why I think it's fascinating, and it's a testament to not only the work being done by our folks at the health department, but other organizations,
Yes.
hospitals, and everybody else that's coming together in this new OB system of care that we're preparing to launch throughout the state, which I think is really it's unprecedented for Mississippi, because we're going to have the first OB system of care that we've ever had. But it's really going to drill down to taking care of moms both while they're pregnant, and then during labor, and then after the baby is born. Can you talk a little bit about that?
Yeah. Well, one thing we do really well in the state are our systems of care. The oldest system is the trauma system that goes back to the 1990s. And then we developed the STEMI system, which is heart attacks, and then the stroke system. And what systems of care does is it first of all lets you know what you have in terms of what the hospitals are able to do and what they're not able to do, and that's important. We learned that you don't want to necessarily, after a car wreck, go to the closest hospital. You want to go to the closest hospital that can handle your trauma, whatever your trauma level is. The same thing with heart attacks. We want to get you to a cardiac cath lab as quickly as possible. And that's what the systems of care do. And so what we've not had with our high-risk moms and babies is a system that help the mom deliver at the right level of care, so she has all the services that she needs to support her risk, and then very importantly, the right level of NICU care for a high-risk baby. Because what's been happening are the moms delivering at the closest hospital, irrespective of level of care, and then us having to transfer her and or the baby quickly, which oftentimes in rural areas does not happen quickly. And time is everything. So the system of care will, number one, hopefully have the moms delivering at the right level of care. But then, we know things happen. Babies come when babies come. That, when they have to deliver at a lower level, that the system will move them quickly and effectively, which, has kind of been hit or miss without the system. So systems of care work really well for high-risk, emergency, time-sensitive issues like trauma, heart attack, strokes, and high-risk moms and babies. We will be the only state with 4 statewide systems of care, and we will be the only state with a comprehensive obstetrical system of care. So a lot of states do parts and pieces of what we're doing, but we're wrapping everything together to really just mirror what we do in the trauma system, which has been so effective for the last 30 plus years. And I'm convinced it will be one of the things that helps to improve our maternal infant health outcomes. When you got your report cards that were less than what your mom and dad wanted, usually there was a corrective action with it. Needs to stop talking so much. Needs to pay attention, or needs to focus on reading, or whatever the teacher said. So the report card in and of itself is great, but what's important is that it informs us what we need to do to get better. And the OB system of care came out of all of this work. The fact that we have got to reduce infant mortality drastically is what has led us to proceed with expanding perinatal care throughout rural areas of the state where we have true obstetrical deserts right now, and plugging that those holes at the county health departments. All of this work has informed us to move in that direction. Seeing in the report card that that obesity continues to be a major problem, that informs us. We have to do something about obesity, and not just keep reporting out every year. Well, this year we were 49th. At least we weren't 50th. That's not what the report card is for. The report card is to show us where we're doing better, where we're doing well, like in vaccinations, and opioid deaths reductions, and then show us where we have a lot of improvement we have to make, like obesity, maternal infant death, firearm related deaths. The top two killers being heart disease and cancers, where we've not been improving in those areas. And so taking that information and moving to action related to that.
What I found fascinating is when you look at some of these preventable death areas, how it all kind of comes back to one anchor. When you talked about moms and being unhealthy, and then you look at hypertension, the high blood pressure, and then you look at the diabetes, and it all kind of can factor back to that one center of obesity, that if we can somehow work on obesity, it's going to trickle down and take care of a lot of other factors, right?
It does. Obesity is at the heart of so much of our poor health, because obesity does drive diabetes and hypertension, both of which drive heart disease and strokes. So, and it's hard to improve diabetes without improving the obesity component. It's very, very hard to do. Likewise with hypertension. So where the money is to really invest in obesity reduction for our state. And it's not well enough for us just to wait for other states to get fatter, so that we're better in our rankings. We've got to slim down, and that's why I've decided that we need to make obesity management part of our core public health clinical services and our community clinics. That our folks we did it with opioids, providing access for opioid use disorder throughout our community clinic statewide, and all the work that we have done together with our partners has reduced opioid deaths significantly 3 years in a row. And I believe a similar model in obesity will work, since we now have state-of-the-art, extremely effective treatment for obesity. And we do have the resources to provide nutritional education and exercise education to our folks. And the population that we serve in the county health departments, typically obesity is more of a problem in the population we serve. So it's not enough just to speak about obesity. It's not enough just to fund other people, to work in the obesity space. We at the health department have to roll up our sleeves and get after it, and that's why we're developing that program right now.
Well, because they've been talking about it for years. It's like that's nothing new from Mississippi. Like, hey, everybody's big. It's the South. Everybody loves to cook and eat the fried everything because that's what tastes good. But in this age now where you're finally done saying, well, we got to stop just talking about it and telling people what are the right things to do. It's when you see us working with the Department of Education trying to get more into the schools and into the kids, and not necessarily to sit through another health class, but just to have things going on throughout the day.
Right. Well, we've been proposing just having 10 minutes, no more than 15 minutes a day of health promotion, and there are platforms where it's the teachers don't have to do an education plan. The teachers don't have to oversee testing or anything. They don't even have to instruct. We are able to generate the curriculum on platforms where basically the students do it themselves, and in a way that's interactive and a lot more fun than just sitting through a health class. The last thing I want is the students and teachers to hate us at the health department, but it's where the action is. That if we, K through 12, are able to just promote good health what it means, how to define it, how to achieve it, then that'll be a generational shift, but you got to start sometime. And it worked with safety restraints in cars. We did that through K through 12 promotion, tobacco cessation the same way. We've got to get vaping under control, and that's where the action is K through 12 health promotion. So just really proud that the Department of Education is a great partner already, advocating that we provide full funding for the Department of Education for the Healthy Student Act of 2007, which definitely showed initial promise in reducing childhood obesity. Very impressive numbers at the beginning when the act was adopted, and then as we typically do, we don't fund it, and really eliminated that opportunity. Had we fully funded that act from 2007, we likely would have childhood obesity under control at this point. But it's not too late. We can fully fund it now and empower our school systems to really do what's necessary to mitigate the obesity that they're seeing right now among the children that they're teaching. And, when you have a third grader who's already obese, that potential years of life lost before age 75, that clock starts ticking. So it's not just enough for us to educate our children well, and we're doing so much better by all parameters. We're doing so much better with education. We need them to be well educated and healthy.
Well, and it starts, they always say if you can get the kids, you can get the parents, because the kids will go home and they'll nag mom and dad to death and say, well, they tell us we need to be eating this at school. We need to be eating like this. And so the more that they can push mom and dad, that then maybe that can make a change at home, so that they can then not only while they're in school, they'll learn healthiness, but when they're at home, it's not even going to help the children, but it's going to help mom and dad, aunts and uncles, brothers, sisters.
It worked with seatbelts, and it worked with smoking. It not only impacted the behavior of the students, but they took that behavior change home. I will never forget in the 1990s when my son came home from school and said, "Daddy, put your seatbelt on." And I did. And I've worn my seatbelt ever since. And now I wouldn't think about getting in a car without putting my seatbelt on. But that all started because my children came home from school and educated me. Because, Lord, my generation, we certainly weren't wearing seatbelts when I was growing up.
No, and it's just ride around in the back of the truck. Hey, that's okay. Perfectly fine.
But, Greg, on the obesity issue, a really alarming fact that most people don't know is that 44% of our preterm births are from moms who are of an unhealthy weight. So obesity even generates premature birth in our state. We lead the nation in preterm births, which causes us to lead the nation in infant deaths. And obesity is a major risk factor. So it's driving almost everything, as you said, including infant mortality.
Well, technology and science is so great, and you as doctors, you work hand in hand with science and evidence-based. And right now, it seems like they've captured lightning in a bottle with these new GLP-1 drugs that are becoming much more available to people. They were just for the really, really sick. You had to prove that you had bad diabetes or were morbidly obese to be able to get that. But now the market is opening up for people to have access to these GLP-1 drugs, which really you're seeing it make a difference in people.
No, they work very well. They're amazing in controlling diabetes much better. So they started, you start getting much better diabetic control right away. But then as you start melting the pounds off that diabetic, then they're not needing as much diabetic intervention. Their blood sugars come under much better control on their own. But the other thing we see with the GLP-1s, the reduction in cardiovascular events, which is the leading cause of death for us. And we're even seeing the reduction in craving for alcohol and opioids. So in the addiction space, we need more study, but there's promising data there that they may be effective in that space. We've already proven they're effective in reducing the rate of end-stage renal disease among the diabetics. So you've heard me say, if we're, it seems like we're determined to take fluoride out of the water after we've had 50 years of success. But if we're going to take the fluoride out, let's put the GLP-1s in the water, and because Mississippi flat needs it with the rate of obesity that we're seeing. The obesity per capita rate is just sky high in our state, and it's driving so much more morbidity and mortality. When you look at pregnant women who are unhealthy in their pregnancies, obesity is a huge correlating factor to that. So, and what's really interesting is the number of women of childbearing age who don't realize the risk of obesity with pregnancy. Nobody's taught them. So we got to teach them. That's where that health promotion comes in. That's just all of our community partners together. We've got to help educate our young women on the things that put you at risk of dying during your pregnancy, or the things that put you at risk that will cause your baby to die.
One of the things, I don't know how if there's a medical correlation, certainly when you're talking about leading causes of deaths and things, but it's also maybe sociology wise. But again, this trend you see on our report card that deaths are outgaining births.
Yeah.
And it's the gap is kind of widening. In 2024, it was 35,245 deaths here in Mississippi, with only 33,471 births. So we're losing ground.
We are from two directions. And last year was our first year with deaths outnumbered live births. And then it happened again. 2024 was the first year. And then it happened again in 2025 that this report card is produced. The birth rate is declining. And that's true nationwide. Now, one of our successes, one reason we're 48th instead of 60th, is that our teen pregnancy rate has been dropping. And that's a good thing. The teen pregnancies are higher risk. Teen pregnancies tend to generate poor outcomes for the young mom. So, helping young women be healthy and choose pregnancy at the right time in their life in the best way possible for them, instead of it just accidentally happening at the wrong time. So teen births, decreasing is very big. We want that, but our overall birth rate is declining, and our mortality rate has not been budging down. So we have excess mortality that's holding high, and we have a birth rate that's declining. So that's not a good equation for a healthy population overall. Our population will shrink further if we don't help reduce our excess mortality rate.
Well, sure, but again, maybe that goes to more of a sociology type thing, where our people are having fewer kids in families
worldwide. Actually,
yeah, that families aren't growing bigger. Is it just the economies? Is it who knows, right?
Well, I've actually read a little bit about this recently, because there are very few areas of the world that where families are having more than 4 children, where it used to be common around the world. Now, just very few areas. But in the developing world, in the developed world, we're down in many areas of Europe to below 2 births per woman of childbearing age. You had to have 2.2 births to maintain your population stable, and like Italy was down to like 1.2, extremely low. The United States is down to less than 3, and we used to be a solid 4. We're down under 3 and dropping. So it's a lot of it is that women of childbearing age are extending their education longer, which is good, and they're delaying pregnancies, because of educational needs and career needs, and whereas my wife and I had our first child when we were 24. My children were all, 29, 30 with their first child. With that, the delaying the pregnancies really dropped the birth rate. And the economic choices, it's definitely a lot less expensive to have 1 to 2 children than to have 3 or 4 or 5. So the socioeconomics is driving this. Change in lifestyles is driving this. And, it's not a change in fertility rates. It's just change in choices. And extremely effective contraception these days with the long-acting contraceptives that really work very well. It's all coming to drive our birth rates down. And but a declining birth rate doesn't worry me nearly as much as an excessively high death rate.
Well, the good part is that I think that you've really found a way to tap into the heart of people here is, I think, probably in their pocketbooks and in their wallets, because I think you've gotten great traction now with our state leaders over at the Capitol that understand that health matters to this state, that they need to invest in health, much as they did education that you talked about.
Exactly.
Because health drives the success of this state. If we're unhealthy, this state's not going to thrive. And it seems like they're perking up over there under the dome for you.
Yeah, and the message is catching on. We did it in education. We can do it in health. 4 years ago, when we started the Change Can't Wait campaign, everybody had the attitude, well, Mississippi is just, we lead the nation in poverty. It is what it is. We've always had bad health. It's going to stay that way. And then I challenged them. It used to be true for education forever, and it's not today. And why not us? Why do we have to all be, as a population, the least healthy in the country? There's no sane reason for that. And I'm convinced the answer to poverty in our state is a combination of improving education as we're doing, combined with improving health outcomes. And, as our population is better educated and healthier, then they will be wealthier. And there will be more economic development in areas of the state that right now are challenging to get because the population is so unhealthy that, there are many employers that just don't want, a workforce that's going to be that unhealthy. So, the best way, I think, to improve poverty in the Delta is to continue to improve education and then work to improve health. We cannot accept the fact that the life expectancy of a African American male is 65 in the core Delta counties. That's horrible for that man, it's horrible for his family, and it's horrible for the Delta economy. That's extremely expensive to the Delta economy. So we can do better. We have to do better. We will be rewarded for doing better.
Well, and the one thing you had mentioned before that hopefully you can kind of reiterate here. What do you say to the folks that say, well, it's personal responsibility. It's up to people themselves to get themselves healthy. It's not up to government to be able to do that.
Well, I'll push back on it's not up to government to do that. It's not up. Lord, we pass laws every year trying to change behavior.
Yeah.
My first response is that is true. As a physician with a long clinical history as a primary care physician treating patients in low-income counties, personal responsibility is a challenge. Medications will only do so much. Patients must and need to change behaviors. Diabetics need to eat better, exercise, and lose weight. COPD patients must stop smoking. There are things that just need to happen. However, do you think the people of Arkansas are more personally responsible than we are? Well, we just passed Arkansas, so I got to stop using that analogy because now we're 48th and Arkansas was 49th last year.
Pick on Alabama.
But Alabama, same thing. You think the people of Alabama are more personally responsible, or Louisiana, Texas? No. So there are many states that have personal responsibility challenges, as we do, who are scoring better in health than we are. So I acknowledge that is a valid issue that we do have to work on. one of my sayings, though, is I refuse to blame the patient for being sick. Now, yes, a lot of life choices led up to them being sick, but none of them had that on their bingo card to be sick. And so I'm not going to blame a mother for dying in pregnancy. There were choices that she may have been able to have made to avert that, but part of that is our responsibility to educate her and help her understand and to help her have better access to perinatal care and make sure the hospital that's delivering her has everything that it needs to deliver her safely and produce a great outcome. I mean, there are things the state does need to do. I would put personal responsibility high on the list, but I'm not about to say that is all-encompassing.
No, I would agree, because you have people that we take it for granted that we've had good education. A lot of folks here have had good education. It's been drilled into your head how to live healthy. Go to the doctor, have access to doctor, get your yearly checkup. But there are folks out there that you just have to realize in Mississippi, they don't have that opportunity, right?
Yeah, and it is a combination. Those who don't have the opportunity, they don't have insurance, which means opportunity falls way off. But we have a lot of Mississippians that do have insurance who don't take advantage of the access that they have. We have folks, there are areas of the state, it doesn't matter what your insurance is, there's nothing there for you. You got to drive 2 hours to get to health care, and that's a big challenge. You have truck drivers. My daddy was a truck driver. Their work life is very different, makes it, they have to come off the road just to go to the doctor. I took care of truck drivers, and it's hard for them to access health care. Shift workers, nurses, God bless them, they all work 12-hour shifts.
And they're surrounded by doctors all day.
Yeah, so and that is a very interesting thing in health care with personal behavior, that there is a very high rate of tobacco abuse among nurses and virtually none among physicians. Shows the stress.
Yeah.
I mean, physicians are under a lot of stress, but nurses they're under incredible stress. And I've always found that really interesting, that smoking rates are extremely high among nurses, extremely low among physicians.
Interesting. Well, the report card, it's got good parts to it. It's got, as you like to say, plenty of spaces for needs improvement, but You've got a good plan, I think, to help set us forward on that.
Well, the population of the state is now my patient, and my patient is still sick, but she's getting better. And we're not as sick as we were 5 years ago, but we're not as healthy, as we need to be. But we see syphilis rates going down, congenital syphilis rates going down, which means we're losing fewer babies to syphilis. I mean, all STIs, including HIV, chlamydia, gonorrhea rates are going down. All those things are, they all come together to demonstrate improved health for the state. But yes, still some corrective action that we need to do, and we can do, and we're determined to do at the Department of Health.
Well, for you folks that are listening, you can go to the Mississippi State Department of Health website, msdh.ms.gov, and you can get a look at the report card itself. And if you want to dig deeper into the numbers, well, we've got you covered there too, because you can simply look at the 2025 annual report, which really breaks these things down to a granular level for those of you that are interested in that. Dr. Dan Edney, our state health officer, thank you so much. We love having you in here, and we're going to have a great 2026, I have no doubt.
Me too, Greg. Thank you so much.
All right, until next time, I am Greg Flynn, and this has been Health Talk Mississippi.